watching Galaxy today. That's Wednesday, and we are looking at health this morning, a 2018 outlook for health, and what we should be looking at this year, the prospect, and of course we are going to just in retrospect look at how far we went in 2017, and we have a guest with us here in the studios today.
Exactly, a renowned medical practitioner. I'm sure in the course of the interview you get to know more about it, but this is a commissioner for health in Ogun State, and that's the person Dr. Babatunde Ikpaye. Good morning, sir.
Good morning, and just to add that Dr. Babatunde Ikpaye graduated as the best overall medical doctor in 1992 with 5 university awards, including the Vice Chancellor's Prize and several other prizes. He also had a private practice in the Idinu Hospital in Ijebu in 1995 and ran it for years before he went for his postgraduate studies in public health and became a fellow of the West African Public Health in 1996. Was a lecturer consultant at the Ogun State University Teaching Hospital, Shagamu, before joining international development agencies. Worked for FHI, UKDFI, and worked for the World Bank then. Now he is the Commissioner for Health in Ogun State. Thanks for joining us.
Thanks for joining us. Good morning.
Justin.
And Happy New Year.
Happy New Year to you. Happy New Year to Nigerians.
Okay, I already feel healthy having Dr. here. All right, Doctor, you have reached TV, means that you've been coming. It's been a long time coming.
Yep.
We're looking at the 2018 health and sector. What do you think Buhari should be doing as regards the health sector?
Well, thank you, viewers, and thank you for bringing me to the studio. There's just one thing we need to do. Just one. If there's just one thing that we need to do, we need to implement the National Health Act.
National Health Act. Okay, why is that imperative for 2018?
Before 2014, there's been a whole lot of, conversations around how health should be delivered. And these conversations are not structured. Sometimes responsibilities are shared in a way that will not deliver quality services to Nigerians in communities where they live. Recall that Nigeria was part of the signatory to the Alma-Ata Declaration in 1978 that prioritizes primary care. And it took Nigeria 10 years to launch that level of care by the late Olikoye Kuti of blessed memory. And so if it had taken us 10 years after we had signed a particular agreement in faraway Kazakhstan, and then it took us 10 years to actually launch it. And in 1988, Nigeria designed and developed its first national policy on health that puts primary health care as the cornerstone of health care delivery. But we have always paid lip service to the delivery of primary care. And please note, primary care is also called minimum package of care, which addresses 80% of healthcare need of more than 90% of Nigerians. It is affordable, it is qualitative, it is based on science, and when you deliver it, many complications that require secondary and tertiary services will have been managed in a cheaper way. And so, not until 2014, when Nigerians, particularly the 7th National Assembly, decided that we need to have a law that will clearly indicate the responsibility of all tiers of government and how that responsibility will be funded. And so the National Health Act was designed, developed, and signed into law in October 2014, and we're still awaiting implementation. Once that is implemented, 90% of healthcare needs of Nigeria will be met. And there are 2 things that the National Health Act prescribes. 1, we need to create a basic health provision fund. 1. We need to create a basic health provision fund. And 2, the Act stipulates how this fund will be well managed. To such an extent that every dollar or every naira that accrue into that fund will provide services to at least 80% of Nigerians in communities where they live. Because this fund will no longer sit at the center, because no Nigerians live at the center. Nigerians live at the state and the local and 774 local governments. At the best, maybe about 2-3 million Nigerians live in Abuja. If you go outside of Abuja, healthcare expenditure must touch lives in Ngiru, in Ijebu, in Abakaliki, in Yenegua. If it doesn't get there, then we will not be providing health. And everybody will now have to rush to the city center to access it or travel abroad to access it, when ordinarily we'll have focused on preventive and promotive care and early diagnosis of cases and treatment before they become complicated and then require teaching hospital services, right? And so, if you have a basic health provision fund that is also going to be resourced based on the provision of that act, the act also says how this fund will be funded. Okay? Section 3, subsection 2B of the act, actually 2D of the act, actually stipulates that this fund will provide basic minimum package for all Nigerians. And so if all Nigerians have access to what we call basic minimum package, that includes treatment of malaria, tuberculosis, HIV and AIDS, hypertension, diabetes mellitus. So what else are you talking about?
Okay. Okay, but
am I communicating?
Yes, you are. But I just want to take you on retrospect now, 2017. I don't know, before we just find the Health Act and all that, which you actually have recommended, let's look a bit at 2017. You know, a lot of stakeholders have actually commented that the health budget for 2017 was grossly inadequate, and we saw a whole lot of issues specifically that year with doctor strike and you know, many issues and breakout in some parts of the country. So right now the question would be that is it that the government is not really concerned about the health of its citizens, that is not really dedicating so much fund, you know, to that particular sector?
Let me say that I agree with most Nigerians that healthcare funding has been inadequate. I agree with most Nigerians. I also agree with most Nigerians that we are not spending wisely, right? But I have been working in healthcare financing for about 10 years, working with, you know, international organizations and in some other African countries. I've supported WHO to work in all countries across Africa where they are not spending more than Nigerians, but they are getting better results. So even if we increase funding and we don't take care of the inefficiencies within the system, we may not likely produce better results. So, while I join others to advocate that government must put more funding, okay, and I take responsibility for that for my state, the first thing to address is inefficiency within our system. If you have a bad meal and you put more grain, you are not likely to have a well-blended output. And so, if we are doing, and I give you the statistics show that we are doing $112 per capita in terms of health system financing. So that means that for every Nigerian, if you look at total expenditure from both federal government, state government, individuals, we are doing an average of $112 per capita. If you compare to South Africa, that is doing $520 per capita, you will say we are not doing enough. If you compare with the United Kingdom, that is doing $3,600 per capita, we are far behind.
Yeah.
If you compare to America, that is doing about $9,000 per capita, I mean, how can you compare with $212 per capita? Yeah. However, America is spending the most per capita in the world, but they are number 17 in terms of quality and efficiency. Okay, so there are some countries like Cuba are spending less and they have a more effective health system.
Okay.
A country like Rwanda in Africa is spending far less than Nigeria. It's doing about $86 per capita. And health indices in Rwanda is 2 times better than ours. So what are they doing differently? So spending more. So the first question to do, because this rhetoric of government putting more has become like the song that we're all singing. But even if government puts more at the rate and the system that we have created, are we likely to achieve better results? In my own imagination and experience, we are not likely. Okay. And so, if Rwanda is spending $86 per capita or less than $100 per capita, and maternal mortality in Rwanda is 2 times or 3 times better than Nigeria, and Nigeria is doing $112 per capita, and we have a maternal mortality of 586 per 100,000 live births, and Rwanda has just about 200, but then there's a problem. Wow. So what are they doing correctly? What are we doing wrongly? And if we have a financing agreement that is able to pool resources, for instance, in the national health insurance scheme. For instance, we go to Kenya. about 60% of Kenya on their national insurance scheme. If you go to Rwanda, almost 90% are on what we call social insurance scheme. In Nigeria, it's less than 4%. So you could see that we are not spending wisely. And then if you have to pay a professor to treat malaria, then there's a problem. Because a professor will earn about 1.2 million naira per month. Okay, but a health care provider that has been trained, provided at the PHC center with what we call standard treatment guideline, we also treat malaria effectively with less than 100,000 salary per. So these are inefficiencies within the system. Okay. And don't create what I call a two-level hub and spoke system that allows majority of the healthcare problem to be managed in communities or where people live, and at a center that will deliver services at a cheaper unit cost per capita. Okay? We keep pumping a whole lot of money into healthcare. We don't get the kind of results that we deserve. But the first thing we need to do is to look at the healthcare need of majority and, for heaven's sake, take it away from the local government, because everybody assumes that local government should fund primary care. It is not possible for the local government to fund primary care.
Why is it not possible?
Because the primary care is the healthcare need of the majority, and the local government receive the list of the federation accounts.
So the issue should be that of funding more of the local government, because since they are closer to the people, ordinarily one would think that they should know the immediate needs of the people at the grassroots too.
But you need resources to provide these needs.
Okay.
And that is what the National Health Act of 2014 corrected. Okay.
Right.
So the National Health Act 2014 says that the basic provision fund, the basic health provision fund, should be funded through three sources. Number one is minimum of 1% consolidated fund from the federal account. You know what they call the federal allocation account. So minimum of about 1%, not less than 1% of that fund. And funding from donor communities and other sources, philanthropies, social groups. But when that fund is pooled, 50% of which will be channeled to provide basic minimum package for all Nigerians through the National Health Insurance Scheme. So it's not going to be spent on the teaching hospitals, on the research center, on flying abroad for meetings, of organizing stakeholders meetings. Rather, it is going to be put into an insurance scheme that provide care for you, me, my mother, your grandparents, everybody. Particularly the four vulnerable classes: women, children, elderly people, and people with disabilities.
Okay, I'd like us to talk about this inefficiency you're talking about. I'm looking at it from the area of manpower. Is that what you're saying?
From everywhere.
Okay, let's look at manpower now. I mean, a whole lot of, let me speak for Nigerians now. Look, a whole lot of us see some kind of inabilities, especially in this primary health sector, where you get to see nurses and doctors that feels like they're incapable, not by license, but probably because one way or the other they just feel inefficient. Is there something the government can do about that?
Thank you. This is like garbage in, garbage out.
Okay.
It is input and output analysis.
Okay.
I mean, unto much is given, much is expected. So if you have the 774 local government that receive 20% of the federal allocation, and they are struggling to pay the salaries of their staff, where would there be money to actually make essential commodities available? Where will you have it? So, and that's why I go back to the National Health Act. The National Health Act says that 10% of the consolidated revenue should be used to build the capacity of staff of the primary care center, specifically. Now, if you're able to put about 300 billion annually, I'm just being hypothetical, and you use 10% of that to build capacity, imagine the change that you will see. The 20% of the consolidated fund should be used to make medicines, consumables available in all primary care centers in Nigeria. That is the prescription of the Act. I didn't write it. But that is the only way primary care can be funded.
Okay.
Another 15% of the consolidated fund should be used to equip and maintain those PHC centers. So that if you go to Rwanda, you see a PHC center that a professor, a businessman will be glad to enter. They are small, cute, beautiful, well maintained, and solves our problem. Only if you get to the district hospital, the equivalent of our general hospital, only 4% of malaria cases get there. 96% of malaria cases are treated in this beautifully built small PHC center that meets your need.
We're talking about malaria now, because I feel at a time like this, there's still I feel there's sicknesses that should have been combated. You want to take a break, just?
Yeah, but before we continue to talk about that, I just got information that Ibadan is standing by. Let's just take input from them before we continue here in Lagos. We have Dr. Ishola Babalola. He's the chairman Association of Resident Doctors at University College Hospital Ibadan, and he is also senior. So now let's look at some other issues right now. Okay, he's talked extensively on medical tourism. I know you might also want to respond to that, but then again, I just want us to look at the issue of NCDs, non-communicable diseases in Nigeria. You know, a lot of people believe that we didn't really handle most of the cases well last year, that we're not proactive, but in your opinion, how would you say we have fared as regards tackling NCDs in Nigeria?
Well, thank you. Let me also appreciate Dr. Babalola. It's been a long time. I left classrooms some 12, 15 years ago.
Wow.
So thank you for acknowledging that publicly. And I recall that in my times with them, the first thing I do is to reorientate my colleagues coming up, that beyond the clinical side of medicine, we also need to begin to understand the economics of health. Because whatever you see in the teaching hospital are just what you call tip of the iceberg, and it is called iceberg phenomenon. For every death from cancer you see in a teaching hospital, there are about 10 deaths in the community that teaching hospital for so many reasons. Religious belief, lack of money, delay, decision-making processes. And even when we describe the system from what we see, the biggest part of the iceberg is below the sea level. We don't see it. And as a community physician, as a public health specialist, I see it because I sit in the community. Okay, now going back to your question, non-communicable diseases, they're essentially lifestyle diseases. Okay. And so we do not have a healthcare system that has been developed to its level of the Western economies that could manage many of the complications of NCDs. So what we need to do differently, and that's for me, rather than slugarizing the need to behave like people that we cannot compete with. Okay, we need to think out of the box and develop our own strategy that is bespoke for our nation and our pocket. All, and I say all non-communicable diseases are essentially lifestyle change diseases. And they are imposed on us by our Western behavior. If you go to communities without civilization, prevalence of many of these diseases are near zero. Hypertension comes with civilization, diabetes mellitus comes with all this food eating, all this sugar, and cancer, some of the cancer, so the more developed you are, the more likely to develop, sedentary lives. We sit on the computer, we eat a lot of junk foods, we smoke cigarettes. Now these are predisposing factors to many of the NCDs. The easiest, cheapest way to do is to prevent them. And so I advocate, rather than, for instance, cancer of the cervix can be 100% prevented. It can be, but if it develops, even in advanced economies, you can cure it. Okay, so when you discuss radiotherapy, chemotherapy, these are expensive interventions that our national health account cannot likely pay for. But the most affordable is for us to focus on preventive strategy. So that as a country will do behavior change communication, we'll be talking to ourselves. You need to do screening. So if you do a pap smear and you detect and you do cryosurgery, which is preventive, you take it off 100%.
But have there been more enlightenment as regards education and
So that is, and that's why I'm here, and that's why that's why I'm communicating to you as strategic partners.
Okay.
Should not be left for doctors and health administrators alone. In countries where they are doing well in community health and preventive and rehabilitative health, It is a multi-sectorial strategy that both doctors, nurses who are primary care providers or secondary tertiary care providers will do their bit. But media houses, okay, corporate entities must engage with those who are knowledgeable to say, we don't have to wait for NCDs to take over Nigeria. We can do something. We do a lot of communication about behavior change for smoking. That's a whole lot of investment that is making cigarette smoking, and those who take that decision to be aware of the consequences of their action. We should do same for hypertension. We should do same for diabetes mellitus. We should do same for cancer. Cancer of the breast. We need to, for instance, in Ogun State, and I make bold to say this. The wife of the governor has taken cancer project as a major intervention, not waiting for cancer to develop. But she has built 3 cancer centers, screening centers, not treatment centers, but screening centers. But these screening centers have supported hundreds of thousands of women. And in the course of screening them, we have picked and operated and taken lump away from more than 3,000 women. These are people that will have developed full-blown cancer and died. And so nobody should be appreciating the value of that investment, because we have not waited for full-blown cancer to develop, and we are looking for one big. Please note, even when you have capacity to treat cancer, the pains that the patient go through in chemotherapy and radiotherapy is so huge that you don't pray your enemy goes through it, even if they're going to be, kept alive. Okay? Every year, Mrs. Amosu does cancer screening for 100,000 women. 2,000 women are picked. And then we see a lump in them. We take them to the teaching hospital in Shagamu. We remove the lump in all of them. Okay? We now know that after we take the sample to the laboratory, there maybe 1-2% are found to be cancerous. They go to do a total surgery. And that takes away cancer out of their life permanently. And for diabetes, you make sure that once you are age of 40 and above, we have a screening mechanism that allows people to be picked when they have glucose disorder before they develop diabetes and diabetic foot and blindness and renal complications. Like 30% of renal cases that will have to go abroad are problem of NCDs, hypertension and diabetes. So if you have managed hypertension and diabetes early, then they don't go into renal failure. And you won't be requiring the kind of renal transplant that we're talking about at the recent time. So for me, yes, we need investment in all of these complex medicines, but our economy cannot afford it for every Nigerian. So what we can afford is what we need to pay for. And that is why, that is the difference between what we are doing in Nigeria and what is happening in Ethiopia, what is happening in Rwanda, what is happening in Kenya. Because we focus more on investing in early detection of cases and prompt intervention rather than waiting. So in 2017 we sat back. We allowed NCDs to develop, to fester. We didn't nip it in the bud. So my position and my advice and my counsel to the Honorable Minister and to my colleagues, Commissioner, is that we need to be a bit more proactive. We need to, do what we call community diagnosis of people. We need to create awareness. We need to do outreaches to screen people, pick them. Because many of these conditions, they don't present with complications. They don't present until they become complicated. Many people are hypertensive. They are running around Lagos without knowing they are hypertensive. So a small screening exercise in Shomolu local government may pick people with BP of 200 and 140 that never knew they had hypertension. And when they are picked, they are treated, stroke is prevented, renal problem is prevented, blindness is prevented, heart failure is prevented. So this is, for me, this is where we need to invest more. So that if we're able to do this for 80% of our population, particularly people above 40, then the number of cases that will have to go to the teaching hospital, to specialist hospital will be reduced.
Okay, so taking it up from what you just said now, what I sense is you're saying that maybe there's need for research, more of the federal government should fund research.
It's not big academic research. We call it community diagnosis.
Okay.
It is not the complex professorial research. Because you see, human needs are so basic. Human needs are so minimal. And so if you are not able to solve simple problems, why are you thinking of a complex problem solution? So it is so simple. You have 10 streak, maybe urine testing kits, HIV screening, malaria testing kits. They come at about $1, 99 cents per unit. I come to Ikeja local government and I screen all adults. And they were able to pick maybe 100, 50,000 people who are in early phases of this condition. I will refer them, go to treatment in Clinical General Hospital, in the Solo General Hospital. That intervention costs about 100 or 200 million. You have screened everybody. So you don't have to now wait to spend 100 million to cure one person that has come with complication. And we cannot afford 100 million for how many Lagosians? 20 million Lagosians.
Okay, now that's for the doctors, but I mean, we have a role to play as well when it comes to this. What would you suggest?
It's very simple.
Okay.
The cornerstone to sustainable financing for healthcare anywhere in the world is health insurance.
Okay.
And the countries that are doing very well everywhere in the world on health are countries that have affordable health insurance. NHS in UK, Obamacare or Trump Care in America, in Germany where health insurance started for as back as 1892. Every country, even when you look at countries that are doing better than Nigeria in Africa, all of them have health insurance scheme.
Let's speak on the health insurance. Not to just put in, I know there's something like that in Ogun State. I think it's called Araya. Okay, so looking at Araya in Ogun State, what aspect do you really think the federal government can pick from that?
Okay, let me tell you what Araya has done to Ogun State. Because when I became commissioner, I saw Araya piloted. No, and I approached His Excellency that we don't need to wait for outsiders to fund our insurance scheme, particularly for vulnerable population. And he gave us all the resources we needed. Immediately gave 100 million, gave additional input, and said, go, I believe you are going to achieve it. But because he had campaigned on a 5-point development agenda, and the second of that agenda is provision of affordable and qualitative health care. And how can you make healthcare affordable if you don't have a social health insurance scheme? And because we didn't have resources to go around everybody, we look at the most vulnerable group, children under 5. These are the people that die most, and pregnant women. And as we speak, the first 1 year we enrolled 16,000 lives. These are people at the lowest quintile of our economic scale. We call it quintile 1. They live on less than $2 per day. Okay? And so these are 16,000 people who either would not have gone to any health hospital, any facility to even seek care. And let me tell you what has changed. Maternal mortality in Ogun State is 119. Nigeria is 176.
Wow.
119.
So maternal mortality in Ogun State is 5 times better than that of Nigeria. Okay, our down 5 mortality is about 4 times better than that of Nigeria. Because we have seen women who we have enrolled for a year of pregnancy that have accessed care, that have had even cesarean section paid for by government. These are people that will have gone to a TBA and probably died, and then a woman in the neighborhood will be blamed for her death. Okay, we've got children that will now, after every illness, go to a hospital, they are treated promptly. Because we have guaranteed financial protection at this point of service consumption. So they go there, nobody asks for money. So you can go there because we have a card, Araya card that we have given. Every month we prepare for this client in 84 facilities. 40 public, 44 private. 4 in each local government area.
Okay, fine. I'm glad you mentioned TBAs.
And the lesson for Nigeria,
okay,
which was your question,
okay,
is that Nigeria needs to unbundle the national health insurance scheme.
You should unbundle it.
Like I told you, no Nigerians live at the federal level. So Nigeria, NHS must encourage formation of state insurance scheme like we have done in Ogun State.
Okay.
And finance that insurance scheme so that, nobody needs to go far away to access insurance scheme. So that the national health insurance scheme become a coordinating entity for 36 insurance scheme that is closer to the people and that is able to make health insurance available to the locals. And so we design a health insurance that is bottom up.
Okay.
And so even in Ogun State, I'm able to pull 500,000 or 1 million persons into an insurance scheme. And Jigawa is able to do the same. And Bauchi is able to do the same. Then we will have an health insurance scheme that is covering less than 4% of Nigerians.
So at the end of the day, there'll be like a wider coverage because you'll be meeting specifically at the state level. Okay, fine. Traditional birth attendant and faith and death. A whole lot of Nigerians still practice that. One would think that this time of development and growth, that some people should know better. So who should be blamed for all of this inactions and these excesses that we have in the health sector?
Nature abhors virtue. And you cannot sit down, I cannot sit down in the comfort of this studio and the comfort of my office and assume I can control people's behavior.
Okay.
Let me make the analysis very clear. It is arrogant. It is arrogant for us, and this is said by Eric Figerist, a medical historian, in the middle of the 20th century. That is arrogant for us to say we can give health to the people. The health of the people is actually their responsibility. Our job is to mobilize them appropriately. And if I sit down and I've not funded primary care, and the closest person to the woman who needs care is the TBA, and I'm not there, what do you expect? That's the reality. So I don't want to sit down and blame anybody who goes to the TBA, because have I provided an alternative? Have I provided the required education to make that person take informed decisions? Okay. So if I've not done all of that and I start saying don't go to TBA, I'll be unfair to the client because I'm not there to support. The woman will have to travel across towns and bridges and roads to get to the nearest health facility. The TBA sometimes are cheaper. They even render services in credit. They don't take money on time. Sometimes they take farm produce. They don't even take money. They take other form of payment mechanism. So we are not competing with them appropriately. And so for us to take care of the health-seeking behavior of people, we need to make our options available. One. Okay. We also need to integrate the traditional birth attendant into our primary care system. Okay. In such a way that we also improve their knowledge. Because their knowledge is also valuable. I have grandparents, our parents deliver many of us in these centers and we are still alive. So what do we need to do? Okay. We need to teach them the modern concept of delivering care, hygiene, sterility, so that in a way they know their limitation. They also deliver their own form of care in a way that it will not harm their client.
Yes, I know that we're out of time, but I just want you to give us tips on how to live healthy this year.
That's simple, basic. First is that we need to respect our body as a temple created by God. Okay. We do not give unto our body what it doesn't need. We must, and that's why most of the emerging diseases are actually lifestyle diseases. Alcohol, cigarette smoking, unprotected sex, and so many things that bring into our body things that will contaminate and make us unhealthy. That's the first basic. The second is that we need to make sure that anytime we feel not too strong, we don't wait until it becomes a big burden. We don't say this little pain. We need to go to the nearest hospital to us and make sure we take good care of us. But above all, we need to take good care of our neighbors. And I tell people that if you have and you don't take care of the have-nots, okay, especially the health system, the have-nots may become a source of infection that will affect your own children and your own family. So we should be looking forward and encouraging government that we have voted for to ensure that we create a pool of funds that we can contribute to. Don't say because I don't fall sick. Because that's our mentality about insurance. But because you don't fall sick, the person that falls sick may be a source of your own infection. So when you pay a token into a pool of funds, first in Ogun State, we're enacting a statewide insurance law that will make people pay a token and government will subsidize. So that we have an insurance scheme. We have used Araya as a case study to see that this is possible. Okay. And that so when we have an insurance scheme that everybody pays the money you used to buy Panadol, Paracetamol, Colanut, or buying, I will put it in the fund, then we'll have enough
to go around for everyone
to take care of that care.
Wow. All right, we must leave it at that. We must say a very big thank you for joining us this morning to look at the issues and the prospect and of course how we can move forward as a country in this health sector. Many thanks for joining us on the show this morning.
Thank you.
Thank you so much, Simon. That was Dr. Babatunde Ikpaye, Commissioner for Health, Ogun State. Thank you so much, sir, for coming to the show. And of course, Dr. Ibisa Babalola, Registrar of Family Medicine in University College Hospital, Ibadan. Thank you so much for being part of the show as well. And for those of us who are out there, we've heard it, we've heard the tips, and we do hope that we'll have a healthier 2018. We'll do this same time again tomorrow. I'm Uche Onyekuluje.
And I'm Justin Academy. A very big thank you to everyone who has contributed to the show. We saw your messages on Twitter and of course